Thank you very much. Assalamu alaikum, everyone. Let's start with the presentation without wasting any time. So, yeah, I'm associated with the Department of Neurobiology here at UC Irvine, and this research that I'm presenting today, it's kind of in conjunction with my PhD work, but which actually started in Malaysia, but now I'm still pursuing it, and together with some animal models, like preclinical study that I'm doing here related to stroke. So let's start with the presentation. So I won't try to emphasize more on the medical aspects of it, because I came to know that most of you are from the medical background, but just skim through it. You know, TBI, like an induced sudden trauma, may like come with contusion, bleeding, bruising, and the major cause of disability in like children, younger adults, because of accidents, usually motorbike accident, but you know, they're also like the violence, gun wounds, sports injuries, etc. So like it's like in the top 10 cause of like death too for from the accident space. So physically, you may know, like it's mostly related with immediate swelling, bruising, contusion, like tearing of nerve, bleeding, etc. Because it's induced from outside the scalp, from the skull. So it may be like a small contusion, or maybe some breakage in the skull, and some object may even enter the I mean inside the brain, so in the white tissue, white matter. So the mental issues that it can affect, that it can incur, is related with cognitive, social, emotional, and behavioral effects, like which may be like change of personality, change of senses, and some something with like traumatic stress disorder. So some symptoms, common symptoms that you know how you can distinguish this. Of course, you know that its physical symptoms is unconsciousness, severe headaches, repeated nausea, dizziness, seizures, weakness, numbness in arms and legs, and related pupils of the eye. Psychological symptoms, you can see like slurred speech, then confusion, agitation, memory, or concentration. So Phineas Gage, for example, was a classic example, and he had already good like symptoms, terminologies there. So yeah. Then the progression of this injury is like similar to stroke. So it has a primary and a secondary injury. So this particular research is actually targeted towards the primary injury. So yeah, but we will also discuss some things that are more about secondary, how to detect that, how to classify it. And the primary area of TBI may also know that it will bring about further neuronal damage, so which is the secondary injury. So then the clinical gold standard usually is a CT scan, because it's more available here in Pakistan, even all over the world. But yeah, people also go to MRI, but you know, it depends upon the severity of the injury, like if it's a mild, moderate, or severe. So if it's a mild injury, then that means that the person, the subject may go through the CT and MRI, is able to do it. If it's a moderate, so still there are chances that the person can do it. But if it's a severe one, of course, a person may be in coma or vegetative state. So yeah, like the regular tests, they are like you may like the well-known is GCS and post-traumatic amnesia. So yeah, you can check for loss of consciousness, and they also like define some particular parameter they like while assessing and diagnosing the injury. So I will skip this part. So yeah, so for medication and surgery, you for like the person who is affected with TBI, the person may require immediate medical response. So like in the ER. So maybe like, you know, requires diuretics to reduce the amount of fluid in the tissue, and anti-seizure medication, convalescing medication. So may require surgery if it's moderate to severe injury, because sometimes the object is inside the brain. So yeah, it's very difficult to like take it out, and then that's how you proceed from there. And then for post-surgery or post-traumatic rehab, so you can you say that patient with moderate to severe traumatic brain injury will need to have intense rehabilitation. Like for example, some like in medical or from military fields, they are unable to walk, unable to keep balance, and yeah, they have to have physical therapies also because of some neural stress and strains. So speech therapy is one more thing. That's just one more area that you may want to look into, because a lot of people have slurred speech because of post-traumatic brain injury syndrome. So therapy may continue for months or years in the hospital. So that's severe disease. Okay, let's have a look at the engineering perspective. It's like if you know that all the neurons in the human body, like they are connected in the form of networks. So all these network connectivities of the neurons and how they behave together is called functional connectivity. You may also know. So similar brain like patterns of activation in spatially separated brain regions, regardless of the apparent physical connectedness of the regions. It's like the actual definition of functional connectivity. So functional connectivity is typically analyzed in terms of correlation, coherence, and spatial grouping based on temporal similarities. Which means that brain regions which are like working together and which are interconnected by like different sets of neurons. The interaction between different regions and their functional outcome, they're actually related. So that's how you assess the issue. Any brain issue related with like any functionality like speech, speech, walking, balance, etc. And the functional connectivity is a non-directional connectivity. It doesn't have duration. I mean, there is another kind of connectivity which is like a directional connectivity, but functional connectivity primarily or essentially is a non-directional connectivity paradigm. So another common understanding of this connectivity is with task networks. So when we are at rest and we're not doing anything, so in simple words, it is a task negative network. That means like we're not performing anything, we're not thinking, but still the brain is still alive, so that it is still working. So this connectivity or very low scale signal is called task negative network. And on the other hand, when we are performing any task, like any function, eating, walking, jumping, whatever, so that is like related with task positive network, so which is actually referring to task positive connectivity. So mostly in task positive, there is a large span of ERP studies. Like evoked response potentials, which change in human brain. Like you may have an idea of dipole, like how they actually perform or how they work. So then there is a concept of default mode connectivity. So usually it's like mistaken with the task negative network, but default mode network essentially is activated with a person isn't focused. Person is very focused on some particular task. So usually this mode is the primary basis of the theories of assessing the functional connectivity. So whenever we try to examine the functional outcome from any brain response, so default mode connectivity is usually the baseline. So that is like we assess those brain signals that are, we get from a default mode network is we keep it as a baseline for distinguishing and the controls. So default mode itself is not, and the brain is at wakeful state. So it may be daydreaming, mind wandering, whatever, but still it is a kind of class negative network, but a very specific kind. That's why the spontaneous EEG, ERP, spontaneous is not ERP, so spontaneous EEG, spontaneous fMRIs, spontaneous MEGs, the spontaneous evoked responses are actually the scope of the task, this default mode network. So it's anti-correlated with task positive network, of course, because usually task positive are actually related with the ERPs, so which are like evoked response potential for functional assessment. So it can be assessed by different softwares. There's a Blues metrics. I cannot even see the screen, like how many of them. There are so many, spanning from the commercial like VESA to the open source like EEG Wave or EEG Lab. There are so many other softwares which are working, like even Brainstorm 3. There's a lot of them available in the market, but there are a lot of issues with them too. When using EEG, it is it has lack of standardization and interpretability. One format is not standard with all of the devices. So mostly this issue stands for MEGs. For EEG, they have pretty much reached a consortium where they have a very standard kind of outcome. So they have a very standard kind of format, but still there is some variety out there which is not so standard, and you can find some not as standard as the MRIs, NIFTY or DICOM. For specifically EEG, you see this .eeg file, and you can see .nb file. There's so many of them. So for example, for MEG, you can find FIF file, .eeg file, .feg, .meg, and even so many formats there. So they're not standardized. And most of the software, they are specifically designed for a very particular format. So yeah, that's why that's one issue. Then clinicians are not comfortable with scripting, of course. These days, here I'm at UC Irvine, so who come to our lab for internships, even they are they're supposed to learn programming, a base, something or fundamentals of R or Python, so to actually assess and analyze these stuff, or maybe MATLAB. So open source and free tools generally lack user friendliness for clinical people, usually because conventionally a clinician was not well versed with the programming, which the trend is changing. So now in the medical research field, that the clinicians are working with a lot of tools, but they are, this change will be there gradually. So yeah. The commercial products, for example, I mentioned VESA, they're relatively more desirable, but they are very expensive. One license is maybe 3K or 4K in US dollar, so which is a pretty expensive thing. So then the clinical diagnosis, usually I mentioned before, think about a scenario that patient walks in. So we have the initial assessment, and from there, if it is suspected that the person has the TBI, so a non-contact and quick brain scan is required. That's what the doctor orders usually in, CT or MRI is the gold standard there, which is readily available. But it all depends upon the kind of injury. If it's too deep or too serious, then of course we have very less time window to actually assess the injury. But all is done with the experienced medical knowledge. So data for neuroimaging modality, if the scan is there, so must be processed urgently with an accurate report of TBI identification, because as soon as you get it, you can try stopping the secondary injury, which is more important, because otherwise it will just go on and chain will not break, and you can get a serious kind of damage, which is usually irreversible in case of severe, like late moderate to severe injury. So clinicians require an accurate picture of the brain. This is actually the cause that which actually pushed us to start working on this particular topic. Now, so issues with existing procedures. These are the open fields. I also mentioned about the software part, like non-standard software thing. That's also an open issue, still an open issue, because different companies have different formats, and they also need to be, the data to be analyzed. That's one big scope where people can collaborate and work. And similarly, like I mentioned here, like there is rapid scanning, neuroimaging modality is vital, because in terms of skull injury, like the scarring or fracturing of skulls, in this case, you will find that it is some technology is required which can give a very good and very clear picture, and very quick, clear picture to actually save the subject. So time window is crucial. So hours of or moderate and the minutes of severe traumatic injury. So yeah. This time window is actually crucial in terms of severe cases, but you know that for severe cases, it's very difficult to take them to the CT because of the condition. Like you don't have much time, otherwise a lot of bleeding will be there, so that's trauma, because of the trauma. So yeah, that's one more thing, that some effective, quick imaging modality may be required, and that is another open issue, open case in the medical science, so in engineering science too. So a scripting-free, quick and clinician-friendly, quick identification and real-time visualization system is also required. So this is one part. This research is actually addressing one of these particular issue, that some modality which can give a very good and clear picture within like 5 minutes, or the very very small time window, so we can assess the primary and secondary injury, and also the extent of the injury. So because MEG is usually like also only over the scalp, so for EG2 is only over the scalp, so you don't see what's going down there in the brain, or inside the brain. So in that case, you may need a reverse solution or something like that, or inverse solution. So that is also not so accurate, because of it's also an open issue. So these are some kind of ideas, it's like they're open, and if anybody wants to work on, so we can just go into those directions. So now for this particular study, why we chose MEG. Like conventionally, like I mentioned, the gold standard is CT or MRI, CT CAT, or this scanning is more readily available. They're like very conventionally used for other diseases too. So that's why in the medical facility, it's usually easy to assess them. But gradually, when we try to go further with that, so of course they have their own shortcomings, and that's why need to have some very good modality which has a very high spatial temporal resolution, and it should be non-invasive, because when the skull is broken somewhere or hit somewhere, so definitely any modality, for example EEG, it actually touches the scalp, right? So in this case it's not useful. That's why people take such patients to like MRI and CT. So MEG is a good response for that alternative for EEG that will give you a good picture in terms of the brain signals. So you can even hear the underlying neurons from by using MEG without even connecting to the brain. You like to see the picture. Even a small baby can get the MEG. So simple. So it's non-contact, it's very rapid recording. It's very convenient in terms, like for example, you don't have to be claustrophobic. So in MRI is a very issue, very regular thing. So yeah, it has a very good signal to noise and field strength ratio. So yeah, that's one more thing. Now some limitations. Limitations like coming to, the first one is like, of course, it is a big machine. So it has, and it's like used to like sniff the neuronal magnetic strength from outside. So definitely it doesn't go give you a picture from the inside. So yes, it may require like inverse solution, but you know it's maybe less effective for like assessing secondary injury once it's there. So definitely it's more useful in the early stage, acute state of the injury. The lack of labeling standards, like I mentioned, that specifically for MEG, it's like I was using a Neuromag Electras. So the Electra has its own like format called FIF, but there are other formats out there too. So Immobile is a very big like CT, and you know I heard like in 2019 they are also working on a mobile version of it, which will be a very good addition to it. It's a bit expensive, like more than even MRI. Now, a bit more engineering aspect is like from a sample space perspective, if you want to pursue research in this area. So just a couple of things that actually work with this particular research too, that we found out that, for example, to address the outliers in like different forms of the time series. So first is like the median is more relevant instead of mean, because you know that your series may be skewed to one side because of some biasness in your data. So because this particular like research is focusing controls, not the cases, and trying to distinguish controls according to the dynamics of the cases. So we have to be very careful to actually model the cases. So that's why like median is better way of representing the data in terms of finding the middle, or you know, the most normal point there. So METCouple is one method which actually uses the strength of median to analyze the difference of the left and right side of this distribution. So you can find the skewness of this distribution. So finally, you can get rid of the outliers very quickly, and you actually know what kind of samples which are more standard. Then its measurement is actually location and scale invariant. So it is a robust statistic, which is much better in terms of medical sensitivities. So this is the basic idea. It's actually a paper from Wong, Siki Wong, and they actually proposed some dynamic methods to distinguish one sample from another. So we're using this idea to actually distinguish the case from controls. So outlier fraction and kernel width are two parameters from SVM, support vector machine, and we're using these two regularization parameters to actually fine-tune our model to actually work in an adaptive or dynamic way to address the distinguish or the hyperparameter between like hyper plane of like the case and the controls. So a bit briefly, like you can say like this outlier fraction is the total outliers divided by the total data points, and the kernel width is the sigma is the defined maximum margin threshold parameter. So which is like I'm just giving you a few example, like different like this nu and sigma values, and you can see different kind of graphs there, right? So that's how you can just distinguish between case and controls. So hypothesis of this study is like the context of graph theory and AI. If we appropriately or adaptively regularize the multi-instance machine learning models, we can get a point in anomalies and with high sensitivity for TBI detection, localization, and scalp activity. So we had a very diverse data set, but I mean, here are some inclusion criteria. So A1632, GCS 9014. So we are basically targeting moderate because they are somewhat associated with both sides. So it's easy for us to actually determine results. So yeah, MEG, the one with one or two channels, and 5-minute eyes open and eyes closed, only 5 minutes. So that's all like for noise removal. TSSS is one good way, which is actually based on the maximal fields of Maxwell's, which actually is very robust signal cleaning or data cleaning mechanism. And specifically, this localize Neuromac comes up with the software which has already TSSS like already in there while cleaning up. While recording the signal. So it can remove the voice beyond this empty room, and there are a lot of artifacts there, like in the heartbeat, etc. It's all gone. It's pretty good. So it does not require reference electrode, does not mix signal coming from internal external sources, can even reduce attenuation due to within head artifacts. So I mean, people can have some good artifacts, like for example, brain plates, etc. So of course they are not supposed to go to MEG, but some small artifact there, it's also prone to that. So press high because TSSS has this strength. Now, regularization, I just give you an example from a paper. Like this is the whole methodology. We have case and control, and then we have MEG recording, and at 5-minute spontaneous at 1 kHz, eyes open and eyes closed. Then pre-processing TSSS, I just showed you. Segmentation, 5 seconds is like of all the segments. Then bivariate feature extraction. Then multi-instance data sets, like we actually in terms of this feature, like MSC means coherence, and the phase-lag index. So just distinguish and distributed with case and control for training, validation, and test. 60, 20, 100, 20. So then we have started the kernel parameters, the sigma at 0.01, a very small step, and training set randomly we use for positive. It's all random. Like in our experiment setting, we use random envelope method. Use metcouple to actually find the outliers from the outlier fraction, create a one-class SVM model. So actually, it's a multi-instance. So for all peer-to-peer or sensor-to-sensor connection, they're all SVMs, and there's a whole bunch of SVMs working on top of this call. So this is how the model works. And then we have a fitness function, which actually checks with every iteration. We have this sigma extended by 0.01, and finally, we come up with some good fitness function, which gives a good boundary between the this outlier, the cases and the controls. So that's how we come up with a model. So for GCS 13 enhanced one-class SVM models instances, we have GCS score 2, so that's how we can just fine-tune it. 10 cross 4 cross validation is the mechanism. That's how we come up with the solution. And here is the major contribution. Then eventually we find all the normal or the controls here. So if we model the control, we can identify the cases. So that's how we find all the electrodes or the points on the skull where we are actually sniffing this data. So we're trying to correlate the two, and that's how we are coming up with a decision boundary, and we can just distinguish anomalous or the cases with normal or control studies. So it's auto-regularized multi-instance one-class SVM is a multi-instance because I told you it's between different brain regions. So we are using support vector machine because it will give us a very good judgment, and it's also very robust. So we're using RBF kernel. So frequency ranges, it works with all frequency ranges, but as you can see here, the beta we have like distributed between low beta and high beta. So for about better results, I'll show you the results. So using conventional SVM, like the regular one, this is a very conventional thing, SMO in Weka, SVM in like Python and R, and in MATLAB you also have SVM function and classify function. You will have this is the standard one that they have set the kernel width at 0.25 and outlier fraction at new. So you get just, 75%, 80% still okay, but for clinical readiness, like for translation, you need something like above 90% sensitivity. So that's why for automatic, the current model, like see, boost this sensitivity to around 93%. So and also like the follow sector pretty better, much better than the clinical one, the conventional one. So this is actually the contribution here. It reaches 93%, 94%. Even in low beta, this is the reason we actually split the high and low beta is 94.14% with specificity of 82.5%, and accuracy is 93.51%. So it is a pretty robust SVM function that we found out. Some benefits, good benefits of it, of localizing it is it's directly localizes the anomalous neuronal connection in default mode. So default mode means the person doesn't have to do anything because somebody who's already injured. So the person may not be able to actually perform any function. So it's all spontaneous, and it just requires a few minutes of like sniffing the brain, and that's how like you get the signals and you get this function. A small like this multi-instance SVM system that generates some good like visualization. For example, I told you like all these like plates or the electrodes from like EEG. It's very similar in like this array is very similar to the MEG one. So in MEG, this from that point of view, you can see that just imagine that you have two brain regions. There's a connection between them. For example, here some issue with the brain, like the person has hit it, like I think it's a prefrontal part. So then you get this like signal that this belongs to the case, and this regular one is belong to control. And you see these all interactions are actually instances of SVM. So there's so many SVM working with each connection. So yeah, it's a bit heavy, maybe heavy on computation, but the thing is like with the model computations, computers even using CPUs instead of GPUs in the regular criteria, like it's still working pretty fast, within seconds. In fact, it's like 10 or 12 seconds is the time. So visualization, you can find like the actual correspondence between the brain regions. So they are all like MEG like electrodes and how they are actually interconnected. So you can see something like that. So if there's some issue there, you will not find those connectivities there. So even if you wanted to do a deep research, you can have like an electrogram or something like any other correlation metrics you can do, and you can just this thing like freely. So finally, the conclusion. So like it's fast detection, like I mentioned, this 5 minutes of spontaneous EEG, like MEG, and like around few seconds of like the system computation. Even on the slower system, it won't take like maybe like 2 or 3 minutes, even in the like the very old systems. So you get some pretty quick results and pretty accurate too. And you see that I say accurate because 93% sensitive, and also like it has this criteria of greater than 90% for clinical translation. And the concept of default mode functional connectivity features our response for normal class is introduced. So this we are using controls as the normal class, and from there like we're distinguishing the cases. So it's this one way of addressing this thing. I mean, and the proposed model is based on MEG, which make repeated scans and assessment possible because it's not like CT or like radioactivity is not there. So that's why you can do it repeatedly. So you can on the course of treatment rehabilitation, you can also evaluate the distinguish like temporal data points like how the rehab is going on, how the brain is functioning. So you can also have a good picture of that using MEG too. So for future work, yeah, I mean, it's an open issue, like I mentioned. So you may be able to get a better picture using fMRI because they are a bit deeper, I mean, deeper in the brain. So, you know, you get those pictures. And from fMRI, you see that, you know, because they're giving a functional connectivity picture. So you have a different, you know, slices of brain. And from there, you can just create a deep learning model to actually distinguish this difference. And they are also very quick, but their sensitivity or actually clinical sensitivity response is yet to be considered, like not there in any study as yet for specifically for the traumatic brain injury and the, you know, assessing the extent of the injury, like I just mentioned about using SVM. So another thing is like it may be used, this deep learning model may be used as an alternative solution at the same time, because it's giving a 3D brain, like very deep brain picture. So you can use that information to actually identify or like find the secondary brain injury, like how the extent of secondary brain injury is going. So that's how it's so yeah, that's about